All right. So, hi, everybody. Welcome. My name is Nicole Lamberson, and I was trained as a physician assistant. I volunteer doing outreach for the film Medicating Normal and host conversations like this one today. Today, our guest is Dr. David Allen. He is Professor Emeritus of Psychiatry and the former Director of Psychiatric Residency Training at the University of Tennessee Health Science Center in Memphis, a position he held for 16 years. Prior to that, he was in private practice in psychiatry in Southern California for 13 years, and he is the author of several books, including a self-help book and 3 books for psychotherapists. We will link his Amazon author page below and some of his blog writings and places that you can find him in the comments if you're interested in looking at his books. Welcome, Dr. Allen. Thank you so much for joining us today.
Thanks for having me.
Yeah, sure. So before we went live, I was telling you that I came across your name because I was over on survivingantidepressants.org, and the patients there have curated a list of good doctors who can help essentially when you are maybe a victim of polypharmacy or you are having a difficult withdrawal syndrome trying to get off something you were prescribed. And I'll tell you what they said about you over there. They said, Dr. Allen, a frequent commenter on various psychiatry blogs, seems to be very responsible about using medications. He says he frequently gets patients who are over-medicated and reduces their medications to the minimum. He sees through the pharma hype. He's skilled at tapering people off medicines. And depending on the situation, he uses a 25% initial decrease, but watches closely, responding quickly to telephone messages for withdrawal symptoms. If needed, he will reinstate and taper more slowly from that point. So only good things over there that are said about you. So that's why I wanted to have you on and talk to you about your opinions and things you're seeing in clinical practice and all of that. So I guess my first question for us to kick off the interview, when we first met over email, you wanted me to know that you are not anti-psychiatry. And so I guess I would just say, let's start with, what are you if you're not anti-psychiatry, and sort of describe your opinion on the current state of affairs in psychiatry, I guess.
Well, I don't think of myself anything other than a good psychiatrist, and psychiatry used to be better. It's been deteriorating as pharma and the insurance lobbies do their tricks on everybody, including the field. They have what the drug companies have something called key opinion leaders, where they get academics to spout their nonsense and stuff like that. So, the psychiatric medications are useful and they're very effective, although not curative in most cases. But that's in people that are properly diagnosed and who are followed closely for side effects and ill effects, and having their labs monitored if that's an issue with any particular drug. But that's just not happening as much, and diagnosis is getting stranger. They've added a bunch of stuff to the diagnostic manual called the DSM, which I think is complete nonsense. For instance, in child psychiatry, it's particularly bad. There was something called pediatric bipolar disorder, which is all over the place. And this one Harvard doctor actually promised the makers of an antipsychotic drug that the study would come out in their favor before he even did the study. And he didn't report all the money he was getting from the pharma companies to Harvard, but yet people were following him. So what used to be called kind of a spoiled brat is now oppositional defiant disorder, and things of that sort. Conduct disorder, it used to be called, juvenile delinquent. That's not there either. ADHD is another big bugaboo. There probably are some people that have some minimal brain dysfunction, as it used to be called, but they're fairly uncommon. Usually there's a reason why people can't concentrate. Like in adolescence, they did a study in Palo Alto that showed that a high percentage of their high school students were sleep deprived because they went to bed too late. And apparently with some of the parenting trends, which is another issue, because parents don't want to feel guilty, even though they are raising some of these people with problems,
Yeah.
but they don't want to have, you're blaming, well, no, not blaming anybody. It's a problem you need to address and fix. But anyways, these people were sleep deprived. I don't know if they were all letting them stay up and play video games half the night, but I've seen that. So yeah, if you're sleep deprived, you're not going to concentrate very well. But all these people that came with that diagnosis could sit for an hour evaluation and focus the whole time.
Right. Yeah.
Another story I like to tell is there was this, when they give something called grand rounds, which is a departmental lecture, this guy came and he was sort of advocating that, half the country should be on high doses of speed, basically. And people always bring up, well, what about these kids? Because there were video games back then, video arcades. And, these kids that get the diagnosis could focus on a video game for hours with all the buzzers and lights going off in every direction. And people mingling around. So how can you say they can't concentrate? And the answer was, well, that's not concentration, which is a standard answer.
Right.
Well, it's not concentration. What is it? It sounds like concentration. So they're not paying attention when people are paying attention.
Yeah. Or it sounds like looking for like underlying, causes, like being sleep deprived, or maybe eating a diet like just loaded with sugar and no nutrients and that kind of thing.
Or there's domestic violence or abuse going on too. That's not in every case, obviously, but that's no wonder they're not concentrating at school if that's going on at home.
Yeah. Yeah. Makes total sense.
But nobody even asked about that stuff anymore.
Yeah. Yeah. It's like just, you sort of tick boxes, like you said, from this list of things in the DSM. And if you meet a few without examining somebody's environment and what's going on in their home and how are they sleeping and this and that, then you can be diagnosed with something and put on stimulants in probably a relatively short period of time, would you say?
Oh, the numbers of people on stimulants is going up. It's also the most widely diverted drug to non-medical, quote, non-medical uses and abuse variation. And that's another thing. When I was a training director, we had a meeting and we had somebody from the National Institute of Drug Abuse telling us the latest theories about why methamphetamine and cocaine were so awful. They reduced the chemical in the brain called dopamine. And I didn't get up to the mic, but I was thinking, and this other guy came up with the question and said, but aren't we kind of giving that to our kids as an Adderall amphetamines? Yeah. And his answer was, oh, but they work so well. Mm-hmm. In other words, he avoided the question altogether.
Yeah.
So that always impressed me. They're not going to go after that, but they went, but marijuana might cause schizophrenia in some cases or precipitate a case. That's horrible. But being a piece of speed, and even the hippies, because California, they are generally in favor of mind-altering substances. I'm not, but they used to say speed kills, and they said that for a reason. And I just thought that was really bizarre. So you have all these societal forces that are working, and some of the academics I went to where I worked. There was one doctor, I won't mention his name, but he was sort of responsible for the diagnosis of bipolar 2, which is another BS diagnosis. I mean, I've seen people that actually met the DSM criteria over 40 years. I saw 2 people that actually met the criteria. They both responded to lithium, so they were probably just a mild bipolar 1. But now there's bipolar 2 and bipolar 3.6 and everything like those. Everybody's bipolar. It's in Katy Perry's song.
Yeah. Yeah.
Everybody. And these people don't look at how long these episodes last. Or if it's really different from the way that the person normally functions. You've got to ask those questions to differentiate. And I specialized in a severe personality disorder called borderline personality disorder, and they were, quote, affectively unstable, which means they were moody and reactive. And people would study how often they were moody, but never study what they were reacting to, which I always thought was like the environment didn't count almost at all. And getting misdiagnosed with this thing and put on all kinds of medicine when they really needed psychotherapy. Now, I have to admit, psychotherapy is my main interest, although I did a lot of psychopharmacology, but I was interested in a behavior problem that most therapists don't like to work with because they're very difficult and they can really irritate you. And I learned over a long period of time how to get them on the right path fairly quickly. They were not easy to treat, and it would take long-term therapy. But you can't do long-term therapy. All the insurance companies just want you to address the latest crisis and then discharge them, and they won't authorize further treatment in a lot of cases, and they pay a lot less for therapy than they do for what they call med checks in psychiatry. So very few psychiatrists now are doing it, and the ones that are sort of old guys that are so psychoanalytic and they're stuck in that craziness. Because I'm also a critic of some of the psychotherapy practices that are going on right now, and that's one of them, that everybody seems to think that everything that's wrong is going on just in your head, and that your environment has absolutely nothing to do with it. Another joke I like to say is that, you just saw ISIS murder your entire family and you're upset. You have poor distress tolerance skills, right? I mean, I'm exaggerating, but that's basically what
the ridiculousness. You're trying to show the ridiculousness of not looking at the whole picture, essentially. Yeah.
And in the 80s and 90s, it was something called family systems therapy, but that's kind of gone out. There's a lot of social workers that are still doing it, but they're hard to come by.
Yeah. So you said initially that you think that when used properly in properly diagnosed patients, the meds are effective, though rarely curative. And then you made a comment too about how, like comparing stimulants to meth. I guess, can you talk a little bit more about that? Like, first of all, how do you properly diagnose a patient if some of the stuff in the DSM is bogus? And then when the meds being effective but not curative, I guess I want to get at, do you sort of ascribe to I don't know if you've read any of Joanna Moncrief's work about how there is drugs have actions, essentially. They don't treat or cure, but they just have sort of alcohol can be an anxiolytic. As can a benzodiazepine. So maybe talk a little bit more about your thoughts on that.
Well, drug is issue. Again, all drugs in every field have side effects. And, there's also a financial incentive for drug companies not to necessarily work on cures, but come up with drugs that you need to stay on pretty much your entire life. And when it comes to the brain, we really don't know how the drugs work at all. I mean, we know what they're good for, but not necessarily how they work. The brain is literally the most complicated object in the known universe. There's millions of brain cells, neurons, and almost, millions and millions and millions of different connections. And you can't narrow them down. And usually a drug affects several of those things. We know sort of how they work in the sense that how the symptoms are going to be controlled or not controlled, and when to switch to a different one when one is not working, and what the proper dosage is. And in something like schizophrenia, which is a real brain disease, I'm sorry, there's no doubt about that in my mind. There's a lot of either or thinking. So everything in the DSM must be a brain disease, or everything must be just a behavioral disorder, and schizophrenia is just another way of looking at things. Yeah, like Alzheimer's is just another way of remembering things. If you don't believe in brain diseases, but you can't do an MRI test and distinguish a disease from just a adaptation to the environment. There's something called neuroplasticity. So not only are they all these millions and millions of connections, but they're changing constantly. It's like a computer that isn't hardwired. So you can imagine how difficult it is. And we made great strides, but they usually, like when they find a genetic effect, it's found in several different disorders. But usually there's at least 30 or 40 different genes that are involved. And the truth is that each gene increases or decreases the likelihood that you'll get a symptom by a very small amount. There's a guy named Robert Sapolsky who wrote a great book called Behave, which just really covered the neuroscience aspects of this. So, but sure, there are brain diseases, but you don't know from looking at an MRI if something's more active than another. Like concert violinists have a bigger part of the part of the brain that controls fingertip movement is larger. Okay, now it may have started out a little bit larger, but it also gets larger the more you play. They did a study of London taxi cab drivers and found that they had a big difference in one part of the brain. So, I guess driving a taxi cab is a disease, right? And that sort of connection.
Yeah.
Kind of had to think, but that's the way people are thinking.
Yeah.
Uh, uh, Another thing I probably should mention is the literature is deteriorating.
Mhm.
Yes. Drug companies like to demonize drugs that are cheap and effective and have gone generic. So now you're hearing that antidepressants don't work. That's
Mhm.
nonsense. What they've done is they include people that are just chronically unhappy in the sample of patients, in addition to the people with depression. And guess what? They don't seem to do much better than placebo. That's because they're not expected to.
Mhm.
You're including people that you know aren't going to respond. It's called dysthymia. They've even changed the name of it to depressive disorder of some other kind of thing. But usually it's just chronic unhappiness, and that's an indication for psychotherapy. It's not an indication for meds.
Mhm. Yeah. So let's pick up on that with antidepressants. Do you feel like they're being overprescribed? And if so, why? Why do you think they're being overprescribed?
Well, because of this sort of blurring of the lines between major depression is a symptom, it's not a disorder. There's
Mhm.
something like 6 or 7 different disorders of which depression or low mood, shall I say, is the symptom. So you have to distinguish what they are before if it's due to a substance, then you have to get rid of the substance. Okay.
Mhm.
If it's a major depressive disorder, that's what responds to medication. Not everybody does, but far more than you see in the literature. And in real bipolar disorder, which is a severe mental illness, but it's episodic, they're
Mhm.
saying that antidepressants shouldn't be used. And first they blame because if you're not on what they call a mood stabilizer like lithium, you might flip into a manic state. That's true. But if you do prescribe a mood stabilizer, then antidepressants are actually more effective in bipolar depressive episodes than they are in single depressive episodes. But they're saying you shouldn't do that. But again, they're include the sample. There was a big study on this, and they actually picked people, and without saying this, that had failed a number of antidepressants in the past, who
Mhm.
were bipolar depressed, and were currently depressed. So of course, you've already got a sample that's kind of resistant. And the only patients that they excluded were those that were on the 2 antidepressants they used in the study, but not the other, 10 or 15 antidepressants. I got in a big argument with one of these academic types about this study is nonsense, and they don't mention that. And
Mhm.
I even had somebody sort of acting as the third person to communicate with one of the main authors of it. And I kept asking, well, what percentage of your patients in the study had failed a previous antidepressant? He would not answer that question. And he had many drug company ties also.
Yeah. Yeah. It sounds like there's a lot of, uh, drug company money mixed up in things. And so it's very hard to sort through the literature and know what you can trust at this point or what's good science or junk science. Um, you said, I believe, that you don't really have much problems or in your clinical practice tapering people off of antidepressants because you don't really keep people on them long term and you would follow them closely. So can you explain more about like how long is long term in your mind, and maybe a little bit about your tapering philosophy or what kind of methods you use?
Okay, if you were properly diagnosed with a major depressive disorder or bipolar depressive disorder, and you
Mhm.
responded to the drugs, usually, especially in unipolar major depression without manic episodes, they argued about how long you should stay on before you taper people off, and we kind of came up with 6 months.
Mhm.
Now, if you've had many, many episodes, you might be put on medicine sort of prophylactically or preventatively, says what that means. But the literature on how good that is a little bit, it's not that great. So after 6 months, we'd start tapering them off. And there is an antidepressant withdrawal. It's not like an addictive withdrawal because you don't have any cravings for the drug itself,
Mhm.
but it can relate, but you can have a lot of strange symptoms. I wrote a list down of here. Uh, Anxiety, insomnia, headaches, dizziness, fatigue, irritability, aching muscles, chills, fever, nausea, electric sensations, and it's very unpleasant. So you
Mhm.
don't want to do that. Now, again, which antidepressant does matter, not because you don't get some withdrawal from any of them, but if you're on a medicine that stays in your system a long time, you almost withdraw yourself. So if you're on a short-acting drug, like class of drugs is called the SSRIs, like Prozac-like drugs. Prozac is in your system for like 6 weeks. You practically withdraw yourself. Whereas Paxil is very short acting, so you're going to get symptoms fairly quickly. So if you're tapering somebody off, usually, like you mentioned, just cut them down every couple of weeks. We decrease it by half. Then instead of pouring the pill into a glass of orange juice and fractionating, you didn't have to go that trouble. You just took it every other day for a while, then every third day, and then you would.
So what about the patients who are like on surviving antidepressants reporting that, their doctors are telling them that, and they're experiencing severe withdrawal syndromes, and they have to do these tiny little reductions in order to make it tolerable for them?
Well, I wonder about those stories, because that just wasn't my clinical experience. You just slowed down the withdrawal.
But you only had your patients on for 6 months, right? Most of the time, or
if it was for a major depressive episode, especially the first or second one, after 6 months, I'd always taper them off. Now, if you've been on it for years and years, maybe that's part of the problem too. But there's another thing, which is called malignant polypharmacy. Talked a little bit about that to you before. So if you have something like a personality disorder, you can have panic attacks. Something like 40% of people with borderline personality disorder have panic attacks, and there's very effective medicine for stopping that. And if you control their panic attacks, by the way, they don't cut and burn themselves as much as they don't self-injure like they're known for as much. It really cuts it down, better than therapy, by the way, and much more quickly. So they always have symptoms popping up of some kind of anxiety or depression or poor concentration, and you get these people that they just put them on another drug. Every time they have a new symptom, instead of evaluating them, they're not seeing them for psychotherapy. So they have no idea what's really going on in their life. And patients don't tell you a lot of stuff that's going on in their life unless you know how to ask them. They're ashamed of family dysfunction. They don't want to broadcast it, or they don't understand why that might be important, because the doctor never expressed any interest in it. So why would the fact that your parents are getting a divorce and they're both alcoholics matter? It should. So they're getting put on all these medicines because of their reactions to the environment, and then the drugs interact with each other, and everybody has different reactions and different side effects. And so if you were on a bunch of drugs, it's going to be harder to get you off of everything. You probably have to go one at a time. And again, if they're short-acting drugs or long-acting drugs, that's another thing. So if somebody was having a lot of trouble getting off Paxil, I'd probably just switch them to Prozac. That would take care of the withdrawal symptoms, and it would be easier to taper them off. So part of the problem is that they're really responding to having been taken off a bunch of different drugs. Now, I also have to mention this. The audience is not going to like it, but there's also something called the nocebo effect. That if you expect to have a bunch of symptoms, it's like the placebo effect. You will, okay? And it's not due to the medicine. It's due to your anxiety about the medicine. So that's got to be ruled out too, But again, I read these stories and I'm going, where are they getting these patients? I mean, I was even when I was an academic, I still saw patients. I never had this much trouble getting people off, and the ones that I did, I would just slow it down. And there'd be no problem. So to me, it's really not that, it's not that difficult if you know kind of what you're doing.
Do you think that there's a lot of misdiagnosis of like you said initially or earlier on in the conversation that, you have to look at other substances to see if they are the cause of psychiatric manifestations of symptoms. Do you think that there's instances quite frequently even where doctors are not seeing people who are on this malignant polypharmacy, or even on just 1 or 2 psychiatric medications that are causing the very symptoms they purport to help? So you're having psychiatric symptoms because you're on psychiatric medications, or because you're making a reduction or something in your dose, or increasing the dose or switching the way that you're taking it. And instead of seeing that as an adverse effect from the medication or withdrawal syndrome, that people are being diagnosed with like a worsening underlying condition or a new mental illness.
Oh, that I'm sure that happens all the time. I mean, I don't have any personal experience because I never, I don't think I hope I didn't do that. But a lot of time there's also substances that people abuse and they don't tell you about.
Mhm.
And there's a certain number of patients that come to you trying to get medications and faking symptoms. There was a scandal in Arkansas, which is near where I live, about 20 years ago, where people were coaching their kids on how to have trouble paying attention. So A, they could get them on disability, and B, they got a hold of stimulants and they were abusing them. So there's a lot of factors you have to consider. It's not that easy and straightforward, but if you haven't spent any time with your patient and you don't know how to look for signs that they're not really telling you the whole story,
Mhm.
You're going to make them worse. And if you're having a lot of if somebody is complaining about something, you put them on a medicine, they get worse, you take them off of that. You don't leave them. Well, let's see how it works 3 weeks from now. No, there's plenty of other options.
Yeah.
People will have a negative response to one antidepressant, but do fine on another. And there's diminishing returns. Usually, though, my experience is if you increase the dose to the maximum or till they had too many side effects and they didn't get better, you put them on a second one. It's diminishing returns as you go on, but very rarely did I have to go to a third one. But that sort of thing happens. And if you can't tolerate them at all, I've never seen anybody that really couldn't tolerate even a low dose. Some people in the old tricyclics would get agitated on some of the medicine, and you just have to reduce the dose. Not everybody needs the dose that's prescribed in the PDR. Some people do better on a much lower dose. That's uncommon, but it does happen. So if you're not monitoring the patients for side effects and how much they're getting better, and one of the questions is, well, how do you tell if it's just a placebo effect? Well, antidepressants, it's sort of easy to, because they don't work right away. They take 2 to 4 weeks to work. So if somebody feels better the next day, it's a placebo effect. So you can kind of tell, because that's another thing that happens. Oh yeah, the medicine's working great. I don't have to deal with my husband who's beating me up anymore because I feel so much better. They're just not telling you, and they don't tell therapists the whole picture either. That's the literature is that you think you're doing the study on like child abuse and you're taking people's word for it. You don't think a bunch of them are lying to you, especially if they know you have to report them if they admit to it. I mean, a lot of strange things going on in the field, and that seems to be more and more of this kind of stuff.
Right. So I guess if you've never really experienced difficult withdrawal syndromes in your patients, then you've never really encountered people with like protracted withdrawal syndromes either.
Well, I occasionally see those through surviving antidepressants. They get my name if they were local, and I'd come to see them. And generally, I would find other factors, or they were put on ridiculously impossible doses to begin with. So then you have to figure out, well, how am I going to treat this problem? Maybe you need for a short time, you need a second medication. Like for instance, if you have to get off tranquilizers, benzodiazepines is another class of drugs that were demonized by the drug companies because they were cheap and effective. Well, again, long acting versus short acting. I didn't prescribe Xanax, for instance, because it was ultra short acting and get addiction effect and withdrawal effects. But if you read about benzos in the literature, it was always followed by the sentence, but of course they're addictive. But if you read about antipsychotics, you never saw the sentence, but of course they could cause diabetes and tardive dyskinesia. You didn't see that. So they're being demonized because, you can abuse them, but unless you mix them with something else, like an opiate, they're almost impossible to overdose on. And if you take too much, you don't get, there's no high associated with it. So you get terminal calmness or something. I mean,
but what about like the black?
But getting them off, let me just finish that up. If you have to get off quickly, there's a way to do that. There's a drug called carbamazepine, which is Tegretol, and you can use that and get somebody off within a month, even if they were on a short-acting drug. You switch them to a long-acting benzodiazepine, and then there's a whole protocol you can go through, and it's not well known. But I've used it occasionally, and it really works. Otherwise, you can definitely get things like what they call rebound insomnia if you're taking a sleeping medication, and you think that you need the medication again. Well, no, you got off of it and it has a known side effect. Okay, so that goes away after. If somebody doesn't know that, and if a doctor doesn't pay any attention to it, there's a whole bunch of other factors that can get thrown into the mix for why the patient's having so much trouble getting off the drug. And of course, there's going to be some people that you just have to go really, really slowly
Yeah.
with.
So just to clarify, when you're talking about benzodiazepines and you say addictive, do you mean like true substance use disorder, or are you talking about the risk for prescribed physical dependence?
Well, it's both really. So physical dependence and substance abuse. Yeah, you get dependent on them. Like I said, you can get, if you're motivated, you can get off of them if you really need to by tapering them off and stuff like that. But they're still, they don't have a lot of side effects. And like I said, you don't want to give them to opiate addicts, particularly because if they mix it with fentanyl or something, they're more like, but you can die of an overdose of fentanyl all by itself. You don't need to add it.
Yeah. Well, the FDA's just put a new black box warning on benzodiazepines. They updated the one about the combination risk of opioids and benzodiazepines, and the new one is about the risk for physical dependence and severe withdrawal syndromes on attempts at discontinuation. So I think there are a population of people.
But there are ways to get you off it if you're motivated. If you're not motivated, then you're not going to get off it. But like Ambien, okay, people were prescribing that for sleep. Like it worked exactly the same way as the benzodiazepines. It was just as addictive. It had some side effects more frequently than the old drugs did. Like people would wake up in the middle of the night, not remember, and go driving places or make elaborate meals. I mean, that happened with benzodiazepines too, but much more uncommonly. So they said you shouldn't use benzo, but use Ambien instead. I mean, that really made no sense because it was a new drug at that time.
Yeah.
And they could charge more for it. So the drug companies demonized benzo and did point out that if you read about it, you knew they both worked the same exact way. There's no reason why you should be on 3 different benzos or on a benzo and Ambien. That makes absolutely no sense.
Yeah.
And then I also get patients that are on tranquilizers and stimulants at the same time.
Yeah,
I
was on all of that. Yeah. Ambien, multiple benzos, and a stimulant. So yeah,
uppers and downers and bears. Oh my! I mean, it made absolute, and that is hard to get people off of when they're on that combination of drugs. So that's another reason why people have difficulty. It's not all due to the drug. Usually, it can be, but that's unusual. Okay, does that make sense?
What about the duration of use? Like for antidepressants, it sounds like you always have an exit plan for people. What about benzodiazepines? I mean, do you feel like short-term use or just intermittent use is the responsible way, or are there long-term reasons to have someone on a benzo?
It depends on the diagnosis and the severity of it. Like panic disorder, okay, for instance, that's a really disabling condition. I've seen people have a panic attack. They can't function, and they can be afraid to go out of the house. It's called agoraphobia. So those people, they may need to stay on it for a while.
But what about tolerance? Because I never had panic disorder before, and from being exposed to benzodiazepines, I developed panic and agoraphobia from the benzodiazepines themselves.
Well, again, that's if you had withdrawal symptoms that could trigger.
Yeah.
I mean, again, mentally it affects you, and also, I mean, I can't really comment on your particular case, obviously, but I mean, it could be a real problem. Tolerance isn't a huge problem with benzos. You can develop some. Again, the population that I saw, you're not supposed to prescribe benzos because they'll abuse it. Well, if they promised me they wouldn't, they usually didn't. And now you can monitor to see if they're getting them from other doctors, at least. And there's no big street market for clonazepam, the last time I looked. So you can kind of tell the people that are coming just for the drug, and you don't give it to them anymore. You taper them off really quickly, whether they like it or not.
Yeah.
So again, it all depends. Like if somebody's cutting and burning themselves, like my patients often do, and the combination of a certain type of antidepressant and clonazepam works really well, although no drug company will study that, by the way. Even the guy that studied antidepressants in that particular condition, when I mentioned, did you ever add on a benzo to see what happened, he acted like he didn't know what the hell I was talking about.
Yeah.
But it's very effective in that population. And the problem, people got tarred with being drug abusers because they would take more than was prescribed, but that's because they weren't being prescribed enough to control the symptoms. And when they increased the dose to where I might put it, guess what? The symptoms went away. So they would keep doing that, and then they get branded a drug abuser.
Yeah.
Of course, they wouldn't
Okay, so I'm curious about informed consent. Like, do you feel like it's being given to most consumers of psychiatry when they first come in and say they're given a medication? And also, what should informed consent ideally look like for these patients before they start taking medication?
Well, you should tell them about serious side effects possibility and that this is what isn't happening anymore. If they have any problem or they think they're having the problem, they need to call.
Mhm.
We had people covering for ourselves after hours, so they could even call after hours. And then you follow them very closely to make sure. And you have to, especially long-term side effects,
Mhm.
like lithium can affect the kidney. It doesn't do it all that often, but we monitor kidney function. You have to do that.
Yeah.
Okay, so you tell them about those risks and you tell them about the potential benefits. It's up to them. They don't like what you're saying. You say, well, you're welcome to get another opinion. I'll see you again if you don't like that one. I mean,
Yeah.
I have no problem with that. Some people get really, oh, you can see another doctor, you don't believe me. Well, no, I
Yeah.
get another opinion. I mean, see which one, so they need to have informed consent over why they're on the medicine, what'll happen if they don't take the medicine, what other options there are,
Mhm.
and that you're going to follow them, and you're going to, if they have any problems, you're going to jump on it right away. I mean, I worked at the VA for a little while, and people would be put on an antidepressant, and they had a follow-up appointment in 3 months. That's nuts.
Yeah. What about though, in informed consent, like the potential for physical dependence and withdrawal syndromes? Do you think
Yeah,
patients
well, if
are
you're putting
being,
them on drugs that do that,
yeah,
and again, when they put kids on Adderall, I don't think they're talking about the risks. Well, you can get marijuana can cause psychosis. What about Adderall?
yeah,
Amphetamines can trigger psychosis
mhm,
quite readily. They can cause sleep problems. Guess what? So you have
yeah,
trouble concentration. Uh, they have a lot of potential side effects, and they're very abusable.
mhm.
Um,
You
so,
worked
but
a lot in residency training, and so I'm
Mhm.
wondering, like, we hear from patients all the time who are shocked that they developed a withdrawal syndrome and that they developed physical dependence because they weren't informed by their prescriber that that was even a possibility. And so when they're ready to come off, they are so upset and feel like they were deceived in some way.
Well, they
But
were.
then, yeah, I guess adding insult to injury,
Yeah.
they tell us that they go back to the psychiatrist or multiple doctors. It doesn't even have to be a psychiatrist. It could be like their family medicine provider or internist and psychiatrist, et cetera, et cetera. And they're coming up against a medical profession that has two problems. I think one is sometimes they're not recognizing that withdrawal is even a possibility or that it's real. So the patients feel sort of gaslit, like, oh, it's, out of your system. That's not what's happening to you. Or number two, they feel like they come across doctors who maybe believe them, but aren't trained or don't know about proper deprescribing protocols. So in your experience, are psychiatrists being trained about physical dependence and withdrawal and how to properly deprescribe patients?
Well, we did, but I can't speak for other places around the country. I mean,
Yeah.
part of that's just doctoring 1A, informed
Right.
consent, side effects, withdrawal effects. I mean, it wouldn't even occur to me, graduated from medical school, not to discuss that with a patient that I was putting
Yeah.
on medication. I mean,
Mhm.
but now you have to understand that the number of business people in the profession has gone up by like 5,000%, whereas the
Mhm.
number of doctors has not gone up nearly that much. And all they care about is profit.
Right.
So you're pressured to see more and more patients in less and less time. I always say, if you go to a psychiatrist and he doesn't spend at least 45 minutes with you the first time you see him, go see somebody else.
Mhm.
A lot of them have trouble finding anybody. Insurance panels will list psychiatrists and they call them and they don't have it. They've moved away or they don't have any openings for 6 months. It's called a
Mhm.
ghost panel. And it's a widespread. It's hard to find a psychiatrist. So people feel desperate and doctors can get away with doing this. And
Yeah.
doctors are kind of wimps when it comes to fighting the system. I hate to say that, but you go through a very hierarchical system as a resident, an intern,
Yeah.
and you kind of learn to do what you're told. And it's just amazing. Like doctors who are complaining about this are told it's, they have low, I talked about earlier, they have low stress tolerance, and they're told to practice mindfulness skills instead of forming a union or something
Yeah.
useful that might actually help them. So doctors are in fact spending less and less time, and you don't have time to go through all of this, and you don't have
Yeah.
time to take a good history. You're going to cause a lot of problems. In the real simple cases, they're going to respond okay. So some of your people are going to do just fine and say, what a wonderful doctor you are. But if there's any complexity at all, you're not going to.
Yeah. It's the patient who suffers essentially
Right.
because the system is so broken. Yeah. Do you think we're casting the net too wide? Are we capturing tons of people who just have regular life struggles that we're diagnosing them as so-called mentally ill?
Well, yeah, again, my population, somebody did a study on this actually, that 40% of people with borderline personality disorder who had seen a psychiatrist before the study were misdiagnosed as bipolar disorder.
Mm-hmm.
There's the differences are just really clear. They make it sound like it's a difficult. Yeah, if you don't know they've had a manic episode, people don't always tell you about them. Yeah, you could put somebody on antidepressant, they could flip into mania, but then you've got a bipolar disorder. So I've seen that happen luckily in hospital settings, so we could get them off of that quickly and put them on a mood stabilizer. But sometimes they don't tell you the history, or they don't know what's important. And even if you take a close history, you get misinformed and something bad happens. But if you follow patients quickly, you'll usually know what to do in that case. I'm sorry, what I forgot what your question was again.
Oh, just if the net is being cast too wide, it just
seems like yes. Anyways, 40%
everybody has a diagnosis at every
everybody
turn. Yeah.
Everybody has a diagnosis. Yeah. If you have any kind of psychological reaction, it's now a diagnosis pretty much. And therapists treat psychological reactions, so that doesn't mean they don't need treatment, but they need psychotherapy. They don't need the drugs, and you can need both. Like I said, in my patients that were cutting themselves and had panic attacks, and I put them on medicine, and then we get to the real reason. If somebody's in a manic state or in a major depressive state, psychotherapy is useless. Mm-hmm. See, that's another, they're blurring these lines, so you can't tell. So the therapists like to point to one study that said cognitive behavioral therapy works just as well as antidepressants. Well, that's totally BS. It depends on the depression. Like you don't see melancholic depression that much. That's the most severe cases because they usually get put on an antidepressant. But we used to see them, and they would have what they call psychomotor slowing. So they were moving at a snail's pace, and they were, oh, you can't do psychotherapy. They can't use it. And it's like giving psychotherapy to an Alzheimer's patient. Mm-hmm. I mean, there's a move to do therapy with schizophrenia, and I go, yeah, you can do supportive therapy so they'll stay on their medicine, but it's not going to help the underlying psychotic process. So there are people that think everything should respond to psychotherapy, and then there are people that think, in my profession, everything needs medication, whether you need it or not, and they don't follow them that closely, so they leave them on for too long. They don't monitor side effects the right way, and that can be disastrous, really.
Yeah.
Yeah.
Yeah. So you mentioned that you think bipolar 2 and adult ADHD are kind of BS diagnoses, and
I think that's just my opinion. I have to say it's my opinion, but from what I've seen, there's just so much problem in the way these things are diagnosed. Don't like the.
Yeah.
There's
people are being marketed to by pharma. So I guess I just want to know, like, if you're just like a regular everyday person and you're having, I don't know, grief, or your boyfriend broke up with you, and a lot of people end up in psychiatric offices for, things like that. How do they navigate a system that, has BS diagnoses? And it's like, how do you advocate for yourself? How do you be a good patient in those situations and make sure that you're not getting diagnosed with some BS thing meant to market to you only?
Well, that's difficult because most people don't have the knowledge base to challenge a doctor that well. But if you have questions, see, they're also running out the door before you have a chance to ask any questions. Speak up.
Yeah.
Nobody does that anymore. If you're an advice columnist, their job is really easy. They just tell people that, why don't you just say that, in a nice way, of course. But if you have questions, or something doesn't add up, or you think, well, what's the difference between major depression and grief? Well, there's a big difference. You can seem to have all the symptoms of major depression. If it goes on for too long, you might have been triggered into a major depression, but they're two different things. And grief can last for 2 years if you lost a spouse or something like that. But most people aren't going to know this, and if they're getting misinformed.
Yeah. Most people, I think, just blindly sort of trust. You have, you've got the white coat on, you're the authority, you went to medical school. And so what you tell me is real, and I should follow your advice to the T.
Well, yeah. So you can read about this stuff. I mean, I have 2 blogs. One's on Psychology Today, and I don't talk about this stuff, but on my other blog, I talk about all of the stuff that's going on with the drug companies and these kind of crazy research. People want to get published, so they look for things that are either obvious or they don't design the thing very well, or they're being financed. The studies being financed by the drug companies, and if it comes negative, those used to not get published. By the way, negative studies didn't get published; only the positive ones did. So you're getting a bias. Again, a lot of doctors don't realize that. I mean, that's frightening, but. They don't. They say, "Oh, you can't bribe me with a pen and a pizza because you go to a doctor, you see the drug reps with their little briefcases walking in, and they used to give you little gifts. They've kind of been told they can't do that. Well, but they don't know how that the pen and the pizza itself isn't what they're doing. What they're doing is in getting you to have a sense of reciprocity. They're doing something for you, no matter how trivial. You want to do something back. They're better psychologists, by the way, the marketing people, than most psychologists.
Right.
They do focus groups, and they know exactly how to do that. I didn't realize that when I first started, but I was invited. There was a new antidepressant called trazodone, which turned out it was too sedating for most people, which, by the way, it's a good sleeper and it's not addictive at all. So I used a lot of that. But well, why would you, they asked me things like, there was a bunch of us, and they'd ask questions like, why do you think you might want to use an antidepressant? Why would you pick one over another? And they were looking for not anything but marketing to you individually. Okay. They get each person's profile. If you don't know this, doctors, when they ever write a prescription, drug companies can look at your prescribing practices as a doctor unless you sign out of the program. So if you don't know the program even exists, guess what? They can tell if you're prescribing more of their drug, so whatever they're doing in your office is working, or you're not, which means it's not working, and they'll try something else.
Wow.
And there was the people that react and go to one extreme. They don't even have drug companies come to your office. Well, I was studying the drug reps, so how would I see what they were doing if I didn't actually talk to them? If you know about that reciprocity thing, then you could sort of, okay, I'm still gonna. It might be a good drug for this, but not for that. And some of it's obvious too if you follow the stuff. Like there was a drug called Abilify, which is marketed as an antidepressant. It's not. It's a dopaminergic drug, which means it's for psychosis primarily, but they can be effective in jobs. So there was in medicine as an add-on drug. So if you can't find an antidepressant combination that works, you can add that on. People will get better. There's other things you can add on first before you get to them because they have their own problems. But that lost its patent and was immediately replaced by Rexulti, which is very similar in the drug. And the commercials, if you watch the commercials for the old commercials for Abilify and you watch the commercials for Rexulti, they're absolutely almost identical on what the takeaway is. That if your antidepressant isn't working, well, maybe your antidepressant isn't working because you were misdiagnosed, or you put on the proper dose, or you really need therapy. There's a whole bunch of reasons why your antidepressant work. Adding another drug isn't necessarily what you want to do, but I mean, there are people that you have to do that with, and they usually get really severe. I had one patient that I thought she had some kind of a dementia. She couldn't remember, she couldn't function. And I should put her on antidepressant. I sent her to a neurologist, of course, because that's what I thought. And I was wrong, by the way. She came back the next day on the antidepressants. It was like she had a personality transplant. All of a sudden, she was sharp as a tack. And wow, I mean, I wasn't expecting that at all. Because, again, you have to rule out other things first. And if you're spending 20 minutes in an initial evaluation, guess what? You're not doing that. So that's a clue, by the way. If your
Right.
doctor doesn't spend enough time and he's shooing you out quickly and doesn't let you ask questions, that's not a good sign.
Yeah. What about insurance companies? Like what role do they play? You mentioned that they can conspire to set rates on procedures and stuff like that. How does that affect the patient?
Well, it's usually they want people to not have expensive treatments because they make more money. That's primarily all of a sudden, that's another thing that's coming up now is these prior authorization problems.
Mhm.
You now have to submit information to the drug company before they'll authorize you to do certain things, and that takes more office staff. So it's also kind of in collusion with these private practices that are being bought up by business, because if you keep having to hire more staff, you don't make as much money, and it starts to look really more attractive to work for somebody else.
Mhm.
And now I don't know if that's what they're really doing, but it sure looks like it to me, because especially in family practice, they're being bought up at an enormous rate. So now it's hard to get a procedure. And again, they won't authorize psychotherapy for ongoing personality issues. Although I didn't have a lot of trouble with that. It was really strange. I only saw my therapy because I have a kind of unique way of treating these people. I only had to see them every couple of weeks, but it would be for 2 or 3 years or 4 years even. And I
Mhm.
didn't have a lot of trouble. I don't know if because they knew I was a specialist and they wanted to get these type of people off their case, because these people could be very, in fact, I was ready to sick my patients on them if they didn't authorize it.
Mhm.
Oh, let me get the name of this person. Yeah, these people that aren't even doctors, who don't know anything about the patient, are making decisions about what you can get and what you can't get. And all this stuff that I'm talking about is all going on at the same time. So you can imagine what a zoo everything
Yeah.
has
Yeah.
become. So I wish I knew I could tell people, well, do this and do that. But other than really educating yourself, it's really difficult
Yeah. It's like
situation
landmines everywhere out there.
everywhere. Yeah.
Yeah.
And doctors are, in defense of doctors, that they're going through this, but they need to speak up. I mean, the American Medical Association, like when managed care came in the 80s, I knew what they were doing because I contracted with some HMOs, and guess what? I could see what they were doing. I was warning people about it. Oh no, we've got to find ways to make more available medicine. Um, it was, but the AMA didn't do anything about managed care as far as I'm concerned. Now they're starting to speak up about some of
Yeah.
these practices. But and the American Psychiatric Association, I got an argument with somebody the other day. I don't think they've done much at all. They're starting to do more. Like there was a law that was passed that said insurance companies had to treat psychiatric disorders just like medical disorders in terms of authorizing care, but they didn't.
Mhm.
They never even came close to it. The law was completely ineffective, and they were AMA was like touting it. Well,
Mhm.
I guess if they enforce it, it might it
Yeah.
might help.
Mhm.
Um, this is not only going on in medicine, but I don't want to get off subject, but this is part
Yeah.
of an even larger problem.
Mhm. Yeah.
Uh,
So before we close, we have like 5 minutes or so left. I want to give you a chance to talk about your books, because you've written some for psychotherapists, and then you have a self-help book as well. So do you want to tell people what the self-help book is about and what they can expect to get from it, who you hope would read something like that?
well, the book is for people that have a really troublesome relationship, adults who have a troublesome relationship with their own parents. Now, I'm not talking about severe sexual or physical abuse. Those people need a therapist, although a lot of the strategies that I talk about in the book also work in those cases, but they're just a lot more difficult to employ. And my editor was saying you probably should address it to sort of milder problems. It's called Coping with Critical, Demanding, and Dysfunctional Parents. And that engenders a lot of, pardon my, always referring to lists, but I want to sort of give you a general idea.
Oh, sure.
Uh, see if I can find it even. Um, okay. Okay, so invalidating is like telling you can't take care of yourself, making poor predictions about how successful you're going to be, blaming their own problems on you, telling you you're oversensitive, calling to check on you every 5 minutes like you're incompetent, taking credit for everything you've done or just avoiding you. Constant criticism and you're never good enough. They're obsessed with your ways. the nagging regarding your parents or your job, and I'm talking about, these are repetitive things. This happens once in a great while. It happens to everybody. It's hard to stop being a parent. I can tell you that. Just because somebody reaches 18 doesn't mean their parents never can give them advice or anything. But if it's going on and pattern, and you try to stop it and it just gets worse, unreasonable demands, either asking for money from you, or hanging out with your friends, or one parent complaining about the other, so they put you in the middle and you're supposed to be like a marriage counselor. Hateful behavior. They're doing things that really irritate you, like telling you to stay with an abusive spouse, or you feel you can't even tell them you're with an abusive spouse because they would tell you to stay with them. Unwanted gifts, gossiping about you and your siblings behind each other's backs and stirring up problems. So these kind of things, a lot of people will tell you it's toxic. There's a book called Toxic Parents. Okay, that's sort of what this is about. And their general advice is either set boundaries or cut them off. But they make setting boundaries is not, you can use assertiveness techniques. And I used to teach assertiveness techniques, but every time I did, my patient would come back the next week with their tail between their legs. I found that the family is much more powerful in reinforcing problematic behavior than I was as a therapist. So you had to deal with that. And I wasn't a family therapist, could barely follow the action with one person talking, let alone with 3 or 4 going on. In fact, the old family systems people used to have, when they designed this stuff, they had two therapists in the session and 2 therapists observing. So I started to learn some of these patterns and why they existed. And it's just not easy. And if you try and talk to them about it, people tend to get mad and defensive, because most people will have a very accusatory tone when they're complaining about something, and that just makes everything worse. So how do you do it? How do you talk about the issues and determine in a way that's going to lead to problem formation? Because nobody's happy with the way things are going on, even though they keep doing it. In fact, I found that if parents are being especially hateful, they're doing it sort of as a favor to you. They can't admit that they have problems themselves. So they think you're better off without them. So they push you away. They can't tell you they're doing that because it wouldn't work. So they do nasty things. Make you want to hate them. And there was it's a gift of love. Hatefulness is a gift of love. I mean, it's most people don't think this way. So
does it have to be parents, or can it be other like close people in your life that are behaving in the same way, like family, but not your mom and dad?
Oh yeah, well, family is always involved. That's the whole thing, and so are spouses. Okay, people don't get married by accident. They can find each other across a crowded room. Their families have similar issues, and one may be at one extreme and one may be at the other. But there's a reason. You're comfortable. What you're familiar with is you're more comfortable with it, even if it's unpleasant. You tend to be attracted to that. So your spouse is probably having similar problems with their parents. You got to deal with that. Your siblings will get in the way if you try to talk to the parents, because they're afraid of what you're going to say, and it's going to make things worse for everybody. So you got to figure out if you're looking for easy solutions, unfortunately, I have to tell you, it's not that easy. You have to do research into the family history to find out why your parents are acting that way. It's great for therapists to say, well, you're that way because your parents treated you this way and that way, but that just kicks the question back one generation. Why are they acting? And the issue of blame always comes up. Why you're blaming, like I was mentioning earlier. Well, it's not a matter of blame, because people are acting that way because we're groupish people. That's the way our biology is designed to fit in with the group. Okay, so we're willing to sacrifice ourselves under certain circumstances. Most people think of, like Americans are all real selfish, and often they are, but mostly with outsiders. In the families, they may look selfish, but they're really sacrificing themselves in a lot of cases. And that's something that's sort of a hard concept to grasp for most Americans, but it's key to figuring out being empathic, in other words, why, without attacking them, so they don't get defensive initially. And it's hard to be empathic with somebody who's figuratively kicking you in the name. And if you get through one layer of defenses, there's 2 or 3 other ones you have to get through.
Sounds exhausting.
So that's what the book, it gives you clues as to what to look for in the family genogram, it's called, going back at least a couple of generations. And it also gives various strategies. I have one chapter that's 17 strategies specifically designed, if they do this, you do this kind of thing. And nothing always works. So there's a strategy when nothing just seems to be working at all. There's a strategy when you're getting into trouble to back off temporarily, so you don't get dig deeper without undoing everything that you've already done. And it kind of goes into detail about this. And again, if you're looking for an easy answer, and again, it's not for just occasional. Everybody has bumps heads with their parents at one time. That's nothing. But if it's a repetitive, ongoing interactional pattern with the same kind of things happening over and over and over again, gender issues are is a big one. People don't remember that not too long ago, women just didn't go to work unless they were poor, but their children grew up like when I did, when the feminist movement, everybody was saying, I can do this again. So they're ambivalent because they have to follow these old rules or their family comes down on them. So it's hard for them to be supportive of their daughters when their daughters are going out to career. On one hand, they'll sort of push them to do that because they want to live vicariously through them. But if they're too successful, they get alarmed and depressed, and they start giving off a lot of double messages. Oh, you can't do that. Men don't like smart women, and this has been passed down from one generation. And politically, you have people on one side saying, "Oh, you're going to ruin your children because you're not home for them enough," and you have other people that the feminists are making stay-at-home mothers into a lesser species. I mean, there's a lot of this kind of going on. Culture. So looking at that as how it's affected your family is sort of key. Figure out how to put an end to it.
Okay. Sounds fascinating, and probably something that, someone who has a family system like that could learn more about how to navigate that situation.
Yeah, and if you can't do it, it's better to cut off parents if they're too tough. Well, there's three choices. You can either put up with it, that's the worst. You can cut them off, which again, people might say they're happy they did that, but they're not. They're very unhappy they did that. And you have a risk of transferring these problems back to your own kids because these follow. Plus, you carry them around in your head, by the way. Go into the biology of that. It's kind of freakish. So that's not the best way. The best way is to try and put an end to these patterns, but that's not easy to do. And there aren't very many therapists that work on this kind of stuff. So again, I don't know what I can tell you other than you read my book, but if you have trouble implementing it, I can't be there to advise you.
Okay. Well, we'll put a link to that book and your other books in the comments and description for people to find it if they'd like to read it and learn from it. We'll also put a link to your Facebook and your blog on Blogspot and Psychology Today. Are there any other places? Do you have a website or any other social media where people can follow you?
I have a YouTube page. It's mostly for therapists, but I just posted one about what I was just talking about. The Rosie the Riveter phenomenon, I call them, because women were sent to work in World War II and they liked it, and then they were sent home and they couldn't do it anymore. And their daughters grew up in the 60s and all the effects that has. So that I have a video about that sort of thing. So I do have a YouTube page, but that's, and like you said, I'm frequent comment on other blogs.
Okay. So people can be on the lookout for you there in those places. And then I guess before we go, do you have any closing thoughts that you'd like to share?
Well, even though I said it's difficult, people can do this. But if you're interested in all these sort of societal things and what's going on in the field, my previous book was for the public. It's called How Dysfunctional Family Sperm Mental Disorders. I don't like the title, but that's but I go into all this stuff about bipolar 2 and all the craziness that I've been kind of referring to here. If you're interested and you want to learn more details, I go into really a lot of details in that book.
Okay, great. Well, thanks everybody for joining us for this live discussion. If you're out there and you haven't seen the film Medicating Normal yet, you can go to our website at medicatingnormal.com/watch for the many ways you can view it. Thanks again so much for joining us today, Dr. Allen. And that's it. Good to meet you. Take care and have a good one.
Take care. Bye-bye.
All right. Bye.